Great, thank you very much, and it's a real pleasure to be here with you today. And my job is just to sort of set the scene by saying where IAPT has got to so far and broadly where it's going to go in the next 11 years. And then there's lots of exciting talks during the agenda which fill in much more detail about how that might be achieved. So firstly, I'd like to start off by just congratulating everyone here in the room who works so incredibly hard in IAPT, because what you've achieved so far is really quite extraordinary, and it's attracting attention throughout the world. But firstly, if we look at our own NHS, on the right-hand side there, you have NHS England's front page on its website on the day of the 70th anniversary of the NHS. Rather typically for the NHS, there's only one thing about mental health on that front page. But thankfully, the one thing that was chosen is IAPT, because the NHS is so proud of what you've all achieved. And you are attracting attention in many other quarters as well. The world's leading scientific journal, Nature, had an editorial describing you as world-beating. The New York Times had a very positive feature-length article recently, certainly much more positive than its articles on Trump recently. The equivalent of the New York Times in Canada had something very similar, and I'll tell you about that at the end. But it is also attracting attention in the Arab world with similar articles in Gulf News. But in many ways, the sincerest compliment is to be copied, and there are many countries that are copying you. So Norway now has 56 IAPT services, which get very similar outcomes to those in England. Sweden has a large section of Stockholm now devoted to IAPT provision. Recently, Israel announced a national IAPT launch. Australia and New Zealand have their own versions. Ontario and Quebec are both starting substantial IAPT programs. Lithuania, I'm told, about 70% of the country is now covered by IAPT services. And LA County has recently just started an initiative. So thank you very much for all you've achieved so far. I'd like to start off by going back to the start of the national rollout of IAPT. IAPT actually started not in 2008, but in 2005, with a lot of lobbying and some pilot work. But the national rollout started in 2008, and it was really a response to a public scandal. We had a very odd situation. For the last 5 or so years, NICE had been issuing guidance on the treatment of mental health conditions, and that guidance very consistently recommended certain evidence-based psychological treatments as leading interventions for anxiety and depression. Of course, medication was often also recommended because it had a good evidence base, but the psychological treatments had the strongest recommendation, largely because of the evidence of them having more enduring effects. But of course, there was a clear statement that patients should have a choice. There are actually over 30 surveys of the public asking what sort of preferences people have for therapy. And in a ratio of 3 to 1, the public across most countries that have been surveyed say they would prefer to have a psychological treatment to medication. There is no country in the world where people have greater access to evidence-based psychological therapy than medication. So the public was simply not getting what it wants. And in England, the problem was really bad. So in 2007, it was estimated that only 5% of people in the community with anxiety and depression were getting an evidence-based psychological treatment. Somewhat more were getting some form of psychological intervention, but it often wasn't evidence-based, and no one was monitoring the outcomes. So that was the sort of public scandal that IAPT was created to try and address. And the IAPT solution, which I know you're all familiar with, was firstly to say we simply don't have enough well-trained therapists. So it starts as a training exercise with the idea that we will train a large cohort of psychological therapists in NICE recommended treatments, following national curricula, and then deploy them in new specialized psychological therapy services following a step care model, because that was what NICE was recommending as a way of implementing treatments on a large scale in a reasonably cost-effective way. And in order to support step care, we also had to create a new workforce, a psychological well-being practitioner who would be delivering the low-intensity treatments, and has proved immensely helpful and successful since then. Also, there was the idea of including employment advisors, because the idea is it's not just a psychological intervention, it's a broader psychosocial one. But initially, the funding for the employment advisors was not really forthcoming. We had very few of them. But many of you will know, and I was talking at an event in Birmingham yesterday, that DWP is now providing substantial funding to bring in the employment advisors into IAPT. It's a wonderful development. There's another revolutionary thing about IAPT, which was really breaking over 60 years of tradition in the NHS by allowing people to go to specialist treatment self-referring. Don't have to be screened by your GP. And that was because there was good evidence that some members of the community, particularly from the BAME community, got reduced access to psychological therapies if we just restricted it to the GP route. And this was a big initiative, so the government quite rightly said, you need to demonstrate that you're going to get the results that you're claiming from the research studies, so you need to collect outcome data on everyone. And very importantly, I think, for the first time in mental health on a national program, it was also said, and this data needs to be transparent to the public. So we need to see how each of the services is doing. Everyone who's using them should be able to Google and see what sort of outcomes there are. So that was the plan. And the plan was not simply based on NICE guidance and the good clinical evidence for psychological therapies and the fact that guidance wasn't being implemented. All governments are restricted in the amount of money they have, and the NHS never has enough money for what we want to do. So a critical bit of the argument was also an economic one, pretty straightforward one when you do the sums. It was to say that this isn't just the morally right thing to do, but it's economic madness not to do it. And the reason for that is it effectively pays for itself. It's a zero net cost. Richard Layard and I estimated at the time, with some documents that went to the Treasury, that the cost of treating someone in IAPT would be about £650 per person on average, but that cost would be more than covered by savings in physical healthcare costs. A lot of people with depression and anxiety also have a physical condition like diabetes, and that condition costs more to treat than if you didn't have anxiety and depression. And there are lots of trials showing you can reduce those physical healthcare costs by taking care of the mental health problem. But also, of course, when people are anxious or depressed, they're less likely to be able to be in employment, or when they are in employment, their mind is somewhere else. They're being less effective in their work. And those also have direct costs to the exchequer, which also would exceed the cost of delivering the program. So we argued it covers its costs twice over. The actual cost of delivering treatment is pretty close to our estimate. It turns out to be £684 on average. And certainly we're now accumulating quite a lot of evidence that we're saving considerable amounts in physical healthcare costs. And you'll see a number of publications demonstrating that coming out quite soon from the IAPT LTC program. So what were the sort of landmark announcements for the program? Well, the program was announced by the minister at the time, Alan Johnson, on World Mental Health Day in 2007. And Alan made several really rather important statements. He realized that this was quite a revolution, and so he stated, we will build a groundbreaking psychological therapy service in England. He also realized that the waiting times for psychological therapies were outrageous, and so he stated that average waiting times would come down from the current roughly 18 months wait for a course of CBT, which is what we had at the time, to just a few weeks as the service rolls out. And then he did something else which was unheard of at the time. He didn't just say how many people would be seen and how long they'd have to wait. he made a commitment to the outcomes that the program would achieve. And he stated in the first 3 years, 900,000 people would have a course of treatment and 450,000 would recover. So that 50% recovery target was established. Some of us had actually told him that if we really did the training well and we delivered the treatment as well as in the randomized control trials, that should be what you should achieve. But he was also warned by many people in government, don't announce that. It's going to be too difficult to achieve. But he really stood up to the plate and said the thing that matters to patients is whether it really helps. And we have to monitor that and we have to report it. To those of us who'd given him the number and were listening, it was sort of like a heart attack moment because you knew you had to achieve it. And people were right in saying it will be very difficult, as you'll see in a moment. However, the early services did do very well. And so when we had a change of government, we moved to the coalition in 2010. They made a commitment to expand the program further in the No Health Without Mental Health document. And then when we had a further change of government, they have twice made a commitment to further expand the program. This is very unusual. In my lifetime, I can't remember what is essentially a social initiative which started by a government on one end of our political spectrum and has been cherished, hasn't even had its name changed, and has been repeatedly expanded as we've moved all the way across the political spectrum. And that is largely because IAPT collects data and demonstrates what it's doing. So it's really difficult not to do anything other than expand it in that situation, especially as very few other services in mental health step up to the plate and do that. So what has it achieved so far? Well, it's a work in progress. We are not at the position that the public wants. We do not have a 3-to-1 ratio in favor of the provision of psychological therapies. But we do have these IAPT services now in every area of the country, in every CCG. We're seeing roughly 1.1 million people a year. Not everyone needs a course of treatment. Some people need an assessment and some advice. Some people have come to the IAPT service, but it's more appropriate for them to be treated somewhere else. They have a different condition and they need to be appropriately signposted. But round about 590,000 people a year get a course of treatment. And IAPT says, if you're seen at least twice, then we need to have your outcome data. And so, as you know, we try and collect measures each session. So even if someone drops out of treatment early, we know how well they've done, and that data goes into the reporting. This is really critical because previously services would only report data on the people who completed treatment, and they would overestimate their effectiveness. So this sort of session-by-session outcome monitoring has allowed us to collect data on about 99%, actually it's 99.4% of the 590,000 people a year that we treat. So we really can see how people are doing. And it's an extraordinary achievement and a reflection to the dedication of all of you who work in IAPT that you've managed to do this. Before we look at what the outcomes are at the moment, I should say a little bit about what the treatment is. So it's a step care model, and this is the sort of latest data on the proportion of people who get the different steps. So about 3/4 of people start with the low intensity intervention. About half of those, so 35% of the total cohort, just have low intensity interventions, often guided self-help, more and more internet supported treatment. But about an equal number of people who start at low intensity then are stepped up to high intensity, and that turns out to be really critical. And then about 1/4 start with high intensity. What are the treatments that are delivered? IAPT is often described as a CBT program. This is not really correct. It is certainly the case that the low intensity interventions are all based on CBT principles, because we don't have low intensity interventions based on other therapeutic schools at the moment. But at the high intensity end, NICE recommends CBT only for anxiety disorders, but it recommends 5 different treatments for depression. And it's very important that patients get a choice. And So the alternative treatments for depression are counselling, couples therapy, interpersonal psychotherapy and brief psychodynamic therapy, and also to reduce relapse rates, mindfulness-based cognitive therapy. And at the moment, 93% of all IAPT services provide patients with a choice of high-intensity treatments for depression. It varies how many different ones that they support. You can see the most common is counselling, and for PTSD, EMDR, as well as trauma-focused CBT is regularly available. Interpersonal psychotherapy and couples are the next most common alternatives. So what are the outcomes? Well, you remember there were some targets here, and currently IAPT, as a national program, is achieving that. So about 7 in every 10 people who have a course of treatment show what we call reliable and clinically significant improvement. And then that is sufficiently large for about 5 out of every 10 person to have dropped out of the clinical range into their anxiety and depression, which is rather arbitrarily called recovery. It's actually 52% the rate at the moment. And we do have some variation among different groups. For some time we had lower recovery rates in the BAME community, but I'm pleased to say that's really catching up now, and there's a very good IAPT good practice guide for BAME community interventions, which was published yesterday, and I'd encourage you all to download it and look closely at the really good advice there. But our current recovery rate is 49.9%. I'm praying that next month it will be over 50%. Okay, however, it's been a journey. So here is the outcome data from the start of the program in 2009 to now. And you can see the red line is the target, the recovery rate, and you can see we were a long way below it at the start. Less than 40%, in fact 37% I think. And it has been a really hard journey to get to where we've got to. Of course the workforce has been maturing and that's helped a lot, but also services have been very creative in looking at their data and learning lessons from it and feeding those things back. And I think this graph is an extraordinary illustration of the importance of public transparency about outcomes. Because if IAPT hadn't been recording its outcomes and publishing it, then we would still be at 37% recovery. Hundreds of thousands of patients each year would not get the benefit that they're getting now, and clinicians would be blissfully ignorant of that point, but we wouldn't be serving the public. So it has been extraordinarily important that we stepped up to the plate and got the data and then learned from it. And every month for the last 32 months, IAPT has exceeded that target, and as you can see, it continues to move up. So how has that been done? Well, the first thing is this transparency. So if you were to Google common mental health disorders profiles tool now, you can see the outcomes of every IAPT service in the country and a great deal of information about them, not just recovery rates or improvement rates, the average number of sessions people get, the outcomes they get for all the different clinical conditions. And this is a sort of snapshot of the area near where I live in Oxford, and this just shows the outcomes from the different IAPT services there. And you'll notice that they vary in their recovery rates from a low of 40% to 63%, but that variation is much less now than it was when we started. And I'd like to illustrate that with this next slide. So what you have here is the dotted line is the national recovery rate from 2015 to 2019. If I did it with effect sizes or improvement rates, it would look the same. All the measures show the same story. So here we had 45% recovery then, we're now up to 52%. But the question is, how's that been achieved? Well, the green line is the recovery rates for the top 10%, the best performing services. And the red line is for the bottom 10%, the least good performing services. And you can see that really the overall change in the national recovery has largely been achieved by the lower performing services really transforming what they do. And as a consequence, the regional variation in the outcomes that people experience in IAPT has dropped from about 20 points in 2015 to now only 10 points. This is a remarkable example of service transformation. In physical medicine, we have quite a few examples of this. We have cardiologists who are doing cardiac surgery for young children, and in some hospitals, your chance of your young child coming out alive after the surgery were negligible. And in other hospitals, they were very high. But the cardiologists got together, they pooled their data, they published it, and they learnt from it. But I don't know of any example in mental health where this has happened, other than in IAPT. And of course, it's really very important to reduce this regional variation, and you've succeeded, which is quite remarkable. So there have been lots of lessons that services have learnt on the journey, and we've tried to put those all together in the IAPT manual. And if you don't have a copy of it by your bedside, you may want to download it and have it there. It covers everything important about IAPT, including not being obsessed by targets and focusing on what patients really want, not just one or two numbers, but also how you can be best supported in doing that. And use that for local conversations with your commissioners as well, to ensure that you have a service that is properly funded, is rightly configured for it to be a good place to work in, as well as to be successful. So what are some of the lessons? I can't take you through the whole manual, there's so many lessons. The first question that was asked, though, in any of the analysis of the data was, does it matter whether you follow NICE guidance? And of course, quite a lot of us like to ski off-piste in our holidays, and some of us like to ski off-piste when we come back to the clinic as therapists. And the question is that advantageous for our patients? And the answer seems to be no. So in the early days, we had quite a lot of examples where the therapies that were given weren't necessarily fully compliant with NICE guidance. So we had a large natural experiment to see what happened. If you look at depression, NICE was recommending counselling as well as CBT, really a similarly strong recommendation. And we find that's right. We get just as good outcomes with counselling as we do with CBT. But if you looked at generalised anxiety disorder, a lot of counselling was given for it, but NICE was not recommending that. It was saying do CBT. But a lot of the counsellors were saying, yes, but we know lots of people with generalised anxiety benefit from our counselling. And they were right. The recovery rates with counselling in generalised anxiety were about 48%. What they didn't know is if it had been CBT, it would have been 58%. So it does seem very important to follow the guidelines. So there was also a social deprivation effect, you may have noticed. But we find that those services in more socially deprived areas have, on average, lower recovery rates. But we also find that that effect is much reduced when you look at the quality of the service. And this slide here illustrates that rather nicely. We've chosen two CCGs that vary enormously in social deprivation. Windsor, you won't be surprised to hear this is not a socially deprived area of the country. And Slough, next door, much more socially deprived. But they both get very good outcomes, rather above the national average. And that's because they're both served by a single, very high quality IAPT service, which is very well funded. And in fact, you might say if the Queen feels in the context of the current turbulence that she might like to go for some treatment in IAPT, she might suggest that the chauffeur drives her to Slough, because if anything, there's a slightly different outcome rate. So that's really where we're up to. Where is the future? Well, the future aims to expand IAPT because it has done so well. So the NHS long-term plan commits to move from 1.1 million to 1.9 million by 2023. That cannot be achieved unless we expand the workforce. So in every CCG, we're hoping that people will take on more trainees and will expand the workforce. You simply can't do it by working harder. Everyone works incredibly hard already. The workforce has to expand. But in addition to that, there's some things that we want to focus on. One linked to this is staff well-being. the services spend an enormous amount of time concerned about the well-being of their clients. But we also need to be concerned about the well-being of our staff. It doesn't work otherwise. So we have to apply the same principles there. And you'll see in the manual a really strong injunction for each service to work on developing their own internal well-being programs which are co-produced between the clinicians and the clinical leads. And I would really encourage everyone to do that, and also focus on the issue of having enough staff resources. The other thing, of course, which is a lot of today's focus, is greater use of digital interventions and also digital triage. So one of the things that happens in IAPT is, of course, because we're such a big program and some other services are less extensive, that many people just get sent to IAPT even if their conditions are not ones that IAPT treats. And a lot of time is spent assessing people who aren't appropriate. And that really reduces clinical resource for treating people who are appropriate and makes life stressful for the clients who find they're not getting the solution they want, but also for the team. So I know there's some work being done in London on digital triage, which we hope will help you with that. Also, we need to deliver the therapy in creative ways. Obviously, the low intensity work is quite creative in using telephone and things, but we have, for example, students who they may start in an IAPT service in one place where their university is, but then have to go home in the vacation and can't have any continuity of care. There is a simple solution to that: video conferencing, and also digital treatments, and we hope the programs will evolve to that. Of course, the biggest area of psychotherapy research is internet-delivered treatments, and we hope that they will become more widely available, and at 12 o'clock we have a discussion about how to do that. You also have Oxford VR here at the conference, which is going to illustrate for you some nice ways of enabling people to confront their fears in a way which is manageable using virtual reality. And this is likely to become much more prominent. And I think you're going to hear about Grenfell in that as well. So I'd like to really wind up by saying thank you very much. I was going to show you a bit of virtual reality, but I've run out of time. And to say a little bit about what those newspaper articles said about you. So the New York Times described you as the world's most ambitious experiments to treat anxiety and depression, and as I said, was very complimentary. The Canadians were typically more direct, and their headline was quite simple: for better mental health care in Canada, look to Britain. And it was IAPT they were looking to. So thank you very much.